In the following video, I will show you the power of 2D strain imaging for dyssynchrony analysis. We will scan a patient with a cardiac resynchronization therapy device with an ICD and two ventricular leads, one in the right ventricle and one on the left ventricular side, implanted epicardially through the coronary sinus. This patient is not my own patient, so I just saw him on the echo table, and we had a programmer from Boston Scientific to program the device to different settings. We scanned him in his own intrinsic conduction, and that was in left bundle branch block, as I was told. I haven't seen the ECG. And then we scanned him at different VV delay settings, so interventricular delay settings between the right and the left electrode, and with standard right ventricular pacing. And we will compare the different contraction patterns as we can analyze them by 2D strain imaging. We will only focus on the apical four-chamber view, and this will tell us the whole story, which is important. We will also look a little bit at Doppler ECG tracings, which can also give us an idea about the effect of resynchronization. Now just a little bit to the background of the patient as it was told to me. He was implanted 5 years before at a university hospital center. He had a non-ischemic cardiomyopathy, left bundle branch block morphology, and at the time of implantation an ejection fraction below 30%, between 25 and 30%. He was in symptomatic heart failure, had dyspnea, New York Heart Association functional class 2 to 3, and had several hospitalizations due to heart failure in the last year previous to the implant. After the implant, he improved significantly. He was very happy with the device, and he had no further hospitalizations. When we saw him, as you will see now later, he had a significant reverse remodeling with an ejection fraction, which is now almost normal. In this situation, it is not always clear when you turn the pacemaker off if the patient is still in left bundle branch block, but in this case, this seems to be the case, and we will see that he is still dysynchronous when we turn the pacemaker off. So what you see here are the images that we took during a session with electrophysiology fellows, which were on a course. We scanned this patient during the course. As I said, I had no ECG available. I just had the echo machine and the programmer of the device. He had a CRT-D device, an ICD, with the 3 leads in the atrium, left ventricle and right ventricle, as I said previously. And we just started in the setting as he came. And one of the fellows knew the patient he was from his hospital, and she told me that they optimized this patient by the ECG. So they obviously looked at the width of the QRS width, they looked at vectors, and they were happy with a programming with an interventricular delay of 40 milliseconds left ventricular pre-excitation. So he came with a VV delay, as we say, minus 40 milliseconds, where the left ventricular lead is pacing 40 milliseconds earlier than the right ventricular lead. And let's have a look how his contraction pattern looks by 2D strain imaging. So we have one cycle here with a VV delay of minus 40 milliseconds, and you see already that the global left ventricular function is really not bad. The ventricle is in a good shape. It is not round, it is not very dilated, and it was before, as I was told, and the patient has obviously reverse remodeled. He has improved significantly by pacing during the last 4 to 5 years. So let's have a look how this pacing configuration, how this turns out in the contraction patterns by 2D strain imaging. For that I go to the measurement menu. There is automatic function imaging, and now the software with artificial intelligence automatically detects that this is a four-chamber view, and it automatically performs the contouring. I did nothing here, and then let's have a look at the result. Well, you see the result here. There was absolutely no interaction. We can discuss a little bit about the tracking here of the lateral wall. This could be maybe improved, but in the longitudinal direction, we have an analysis of all the segments of the left ventricle. We have a global longitudinal strain of 14.2%, which is slightly lower than normal. So it's not completely normal, the left ventricular function, when we look at global strain. And when we try to see, is there any dyssynchrony? No, there is not much. All the segments are practically shortening, and that is below zero. That's the shortening in the longitudinal direction, the contraction during systole. They are shortening almost at the same time. If you want to pick out one or two segments which maybe seem to shorten a little bit earlier, it looks like the basal septum and basal lateral wall. But overall, this is a very synchronous pattern. Not all segments reach the same absolute value, the same negative value for the maximum, but they contract very synchronous. So we store this pattern, we store the result. And this is how the patient came. So with biventricular pacing minus 40 milliseconds, this obviously looks very good. Okay. Let's now turn the pacemaker off. When we turn it off, we just inhibit the pacing. You see immediately that there is some rocking, just turning on and turning off, and that's an immediate effect. So there is some rocking here, and obviously the ECG looks broader. If you would have a look at the 12-lead ECG, he would go back to left bundle branch block. Let's have a look at the analysis here. While the apical lateral wall is not completely within the image, only during systole, that might be a problem, but let's see how the software does. Again, there is absolutely no user interaction. It's fully automated. It's again identified as a 4-chamber view, correctly identified. And this is the result. And actually, what you see here, while the global strain is not much worse, but the patterns here have changed, and they show now classical dyssynchrony as we see it in left bundle branch block. Yellow and light blue and green, these are the septal segments. They shorten very early. Yellow, light blue, and green. And they reach an early peak before aortic valve closure. Aortic valve closure here is only set according to the cycle length. It can be corrected manually, but in this case it's just automatically set. I did not check this if this is absolutely correct, but usually this works quite well. So the septal segments, they shorten early and have a peak early before aortic valve closure. At the same time, the apical lateral wall, the mid-lateral wall and the basal lateral wall, they shorten later, and there's a sequence here. So apical lateral first, mid-lateral, and the latest segment is the basal lateral segment, which not only shortens later, that's when it becomes negative, but it is lengthening. It is still relaxing. It's still lengthening during early systole. And this is a significant effect of dyssynchrony of left bundle branch block. Half of the ventricle is shortening, and the other half, roughly, is still relaxing and lengthening. So there's a lot of wasted work during this contraction pattern, during this delayed electrical activation. Then the basal lateral segment, it shortens late and it reaches a very late peak. also here the midlateral reaches the late peak in post-systole after aortic valve closure. And it's very nice to see here the sequence of contraction, very typical for left bundle branch block, just by turning the pacemaker off. Okay, so we have seen off, the patient gets worse. If the pacemaker would have a problem, he would probably go back over months. He would go back to left bundle branch block, and he would over months probably deteriorate again. Now, as I said, the patient is in BV minus 40, LV minus 40. Why not set him just simultaneously? His cardiologist looked at the ECG. We will check this by echo. So what happens if we look at the same patient with simultaneous pacing? This is now simultaneous pacing with a 0 VV delay. This is the out-of-the-box setting, as probably most physicians after the implant would send the patient home without further optimization. It doesn't look so bad, does it? It's not so much rocking as we had with his left bundle branch block during his intrinsic conduction. But let's have a look. Maybe it's still not as good as the first setting. And again, I start here. The software does it all alone. Artificial intelligence. I do not interact. Now it's tracking. And well, this is the result. The absolute value for global strain is a little bit lower, so worse, less negative. But that is not actually what I look at. What I look at are the curves, really the dyssynchrony. And now you see here with simultaneous pacing, simultaneously pacing the lead on the left side and the right side, it's not as perfect synchronous as we had in the first analysis. If you want, go back in the video and look at the first analysis. And here you see that actually the first contracting segment is the green and this purple segment. So the apical segments, and that's actually where the right ventricular lead is pacing. So there is too much dominance of the right ventricular lead. It is not an optimal fusion of maybe intrinsic conduction, left and right pacing, but the right ventricular lead is pacing first and leads to early contraction of these segments. Then the blue segments are contracting, and then the yellow and the right segment, so the basal segments, are the latest. Now, it's not so much, there is no segment which shows early lengthening, so it is not as bad as left bundle branch block, but it's not as perfect as a minus 40 millisecond setting. And you see here in particular during aortic valve closure, there is still a lot of early peak and a second late peak, so it's not completely synchronous. So we would say here we can confirm that the setting which was chosen by the cardiologist with BV minus 40 was the optimal setting, or is at least a better setting, better than 0 VV delay. Okay, so that's important. We will leave him in his BV minus 40 setting. But what would happen if the left ventricular lead fails? What would happen if we have an exit block of the left ventricular lead, or maybe if we would have just right away implanted a conventional older right ventricular pacemaker in this patient who's presenting with left bundle branch block? So we will now look at the effect of conventional right ventricular apical pacing. And this is this setting here. Here it's written RV. And you see already there is some bulging, there is a little bit of rocking. Many years ago we would have called this, or we maybe still calling this, relaxation abnormality. There is something wrong with the ventricle, and that is right ventricular pacing. Again, I do the analysis. I choose AFI, automated function imaging, does it all alone. Wait for a second. Always check that the software did the right thing and it's correctly identified the correct view. There is one segment which is not recognized. I try to go back, and here I would correct a little bit. Maybe it's included now in the analysis. Yes, it is. So sometimes you need a little bit of correction. Again, we have a global strain around 40 to 15% negative, minus 40.8%. But you see here also now with right ventricular pacing, it looks almost like the left bundle branch block. But now it's not the septum which is early, it's still the apical segments, because here is the right ventricular lead, early shortening, then the mid segments and the basal septum, and there is during the early systolic shortening of all other segments, the basal lateral segment here, the red one, is still lengthening, it's still relaxing, it's coming very late, it's not activated yet. It's late activated, there is early peak of most segments, and there is a post-systolic peak of the basal lateral segment. So it's a left bundle branch block like dyssynchrony by RV pacing. RV pacing would leave this patient in heart failure. It might even aggravate heart failure. And you may get a simple idea of dyssynchrony by looking at the pre-ejection intervals by either pulse wave or continuous wave Doppler across the aortic and pulmonary valve. And we have here the aortic valve, but I will start with the pulmonary valve. The tracing is not very good here, as you can see. Let me choose here maybe the continuous wave Doppler. We have clearly a poor tracing, but you can appreciate the onset, and that is important, the onset of outflow. There is a small artifact. And if we measure here, we can measure the right ventricular pre-ejection interval or pre-ejection period, and we measure this from a reference point on the ECG. We choose a reference point which we will use also for the aortic valve. And I start with the onset of the QRS in this one channel ECG, and I measure to the onset of outflow, even in this bad tracing. And it gives me 97 milliseconds. Now let's move to the aortic valve. And we do the same measurement with the same reference point, that's important, from the onset of the QRS, so look down here, to the onset of outflow. And you see how late this is, 180 milliseconds. And we have an interventricular mechanical delay, as we call it, a delay between the outflow of the pulmonary valve of the right ventricle and the left ventricle across the aortic valve of 83 milliseconds. That's a significant delay. What happens with CRT? So these are our first images. Again, I have a continuous wave Doppler here across the pulmonary valve. Not a good quality, but we can appreciate the onset. The ECG is different, of course, because it's now a different configuration. It's a paced ECG. But we compare now again with the same ECG, pulmonary and aortic valve. So I move on. I take the right ventricular delay, which is in this case 111. I go here and second one 118. So it's about 110 to 120 milliseconds. And we compare this to the left side, to the aortic, and make sure it's the same Doppler modality. So if you choose continuous wave, then take it for both measures. And with the LV here, we now have a left ventricular pre-ejection period, which is much shorter. It can be due to the change in reference points, but the interventricular delay is also much shorter. It's almost not really, but well, it's almost 20 milliseconds, which would be the upper limit of normal. It's not completely normal, but it came down from 80 milliseconds to 28 milliseconds. So you, just by the simple Doppler method, you can also appreciate that you obtained some degree of resynchronization. It's of course not as exact as the 2D strain method, but if you don't have 2D strain available, that's a quick check of your CRT resynchronization effect. The last thing that I want to show you is the effect on transmitral Doppler. The effect on the transmitral Doppler inflow, on the pulsed wave transmitral Doppler, is often much more clear in a patient who is borderline decompensated. This patient here is not decompensated, so the effects are not as clearly visible as it is often in the decompensated patient, but still we see a difference. And we have here again on the left side the transmitral Doppler during off-pacing, and on the right side it's during on-pacing. And I just want to compare with you the duration of the transmitral filling during off-pacing, and I check always for the cycle length here. We have 385 milliseconds with a cycle length of 970. So this, if you take it as a percentage, this is clearly below 40% of the cycle length. When we turn the pacemaker on, and again it's an on-off effect, we see here now with the optimized setting a transmitral filling of 479 with a stable cycle length. So transmitral filling has significantly improved and is now more than 50%, almost, or roughly 50% of the cycle length during the same beat or during the following beat. So just the percentage of transmitral filling, percentage of the cycle length should increase to around 50% during pacing. At the same time, you must check that with pacing that the A wave is not foreshortened. The effect on the transmitral filling is mainly an effect of the AV interval, so the delay between the atrium and the ventricle. So make sure that the A wave during intrinsic conduction, left bundle branch block here, is not longer than during pacing, and that's not the case here. The opposite is the case. It's longer during pacing. If it's shorter during pacing than during intrinsic conduction, then you must question whether the programmed AV delay is too short and that ventricular contraction occurs too early and interrupts with atrial filling.